Hi, good afternoon, everyone. It's so nice to see old friends and making new friends. So I'm Mo Yin. I'm an infectious diseases physician from Singapore. I trained clinically in National University Hospital, which is just next door. And then I had the privilege of doing a PhD with Ben Cooper from Oxford. I was living in Bangkok, where I met the wonderful Pipan here, who now leads the modeling unit at Mahidol Oxford Research Unit. And also with me here is Ye Wei.
I'm a second-year PhD at Duke NUS Medical School.
Okay, so we have a variety of people here: policymakers, clinicians, people from agriculture, clinical background. So I try to put something together that will make sense to everyone, and yeah, welcome any questions, discussion at the end. So, okay, great. Yeah, so some of my slides will overlap with what's presented already. I will start off my first half of the presentation with some epidemiology knowledge that we already know, with emphasis on the clinical aspect. And then the second half of it will be on the modeling part. So this is the same study that was presented earlier. This is led by the Graham study group. And this group of people was sitting in my office in Oxford, trying to hoover up data and entering the data and modeling the data. So what they found is that multi-drug resistance is now the third cause of death in terms of global disease burden. So first and second being heart attacks and strokes. And so the top few organisms that's been identified are key organisms that's causing diseases in our region. And they are mainly gram negatives, including third generation cephalosporin resistant E. coli, as well as carbapenem resistant Acinetobacter. And especially in Southeast Asian region, Acinetobacter is a huge problem. And as we know, carbapenem is a last line antibiotic. So now when we treat patients with carbapenem resistance, we are just shooting in the dark. We have no idea what to treat these patients with. So this is a familiar chart again. We can see that the red colored boxes are the diseases with the highest burdens. And again, we see a lot of them being gram negatives. They are usually enterobacteriales like Klebsiella and coli and non-fermenting organisms like Acinetobacter, Pseudomonas, and Stenotrophomonas. Staph aureus was on our minds maybe a decade ago. There were a lot of them, but miraculously they seem to be coming down, perhaps with better hand hygiene practices in the hospital setting, and the clonal Staph aureus strains in the community seems to be coming down as well, at least in Singapore. So in terms of the infectious disease syndromes that the patients are dying most from would be bloodstream infections, BSIs, and lower respiratory tract infections, so pneumonias. And Pipan asked a really, really good question earlier. How do you differentiate attributable mortality, shaded by the dark purple over here, and the light purple, so associated kind of a mortality? That's actually the answer is we don't know. Yeah, so most of these data come from conveniently collected databases, and most of these data come from microbiology labs. As we know, we take cultures differently from patients. So say in East Timor, where we work in as well, for blood cultures to be done, they needed to ask their relatives to donate blood to make the agar so that their relatives who's sick can do a culture on the blood agar. And in Laos, we know that there's 2 goats outside the lab. So every time they want to do a blood culture, they need to bleed the goat. And when we went to Mongolia, to the Philippines, even some of the so-called upper middle income settings, in their fridges, we see bags of blood that they buy from neighboring farms so that they can make their blood agar. And in Bangladesh, where we have colleagues as well, they tell us, oh, it's so much cheaper to just give antibiotics. Why do a culture anyway? Right? So as you can see, these kind of practices in collecting cultures will be so different in UK, in Singapore setting. When we go for ACMID last year, I was so surprised when there was a big talk about how to stop people from taking blood cultures because there's so many of them, right? So the divergence is huge, and therefore the data set that we get from these kind of lab kind of settings, it's very biased and context dependent. So how do we then proceed to attribute AMR to infections? I will share with you a little bit later on. So subsequent 3 slides are the last set of data that's available to the public from 2011 to 2019. So these are the data that's available before COVID happened. And we all know that during COVID, nobody really had time for anything. So antibiotic stewardship was non-existent, and now we have more AMR now, but this is the trend before the pandemic. And we can see again, the vast majority of the infections we have in Singapore are from gram-negative infections, and the kind of carbapenem infections, carbapenem-resistant infections we have locally is far and few in between. And you can see here, Pseudomonas and Acinetobacter are downtrending. And as you know, these kind of non-fermenting organisms, they like to live in water pipes, and they are really better dealt with in higher resource settings where there's better cleaning and infection control protocols. But for example, in Thailand and Nepal, every other patient has Acinetobacter in the blood or respiratory tract. And if we were to focus on carbapenem-resistant organisms in our hospitals, we can see that there's various mechanisms of resistance, but the commonest ones are NDMs, OXAs, as well as KPC producers. And this epidemiology is again different from the West. In the Europe and US settings, you'll see a lot of OXA and KPCs. But this bar over here, the NDMs, and so New Delhi, first discovered in New Delhi, it's extremely hard to treat, and most of the newer antibiotics cannot treat these type of carbapenem-resistant organisms. And this slide is just to impress upon you, not to scare anyone, but there are a lot of acronyms here, but I just want to impress on everyone that there's so many different types of resistance genes and mechanisms. And here I am just showing you one particular type, which is carbapenem resistance. And there's multiple types of genes, and this is the genes that can be transferred between species, and there's also clonal kind of expansion of resistance. So it's extremely complex. Okay, so just to impress on everyone again, the importance of doing really good surveillance studies and how do we actually attribute mortality to antimicrobial resistance. And as I was alluding to earlier, it is not possible to do that with conveniently collected data. And therefore, with the Advanced ID Network, which is based right here in the School of Public Health, we are carrying out this ACON-HAI study, which stands for a clinically oriented antimicrobial resistance surveillance network for healthcare-associated infections. Quite a mouthful, but basically, we are doing individual patient-based data collection, where we collect their demographics, their prior healthcare exposures, their infection episodes, how severe the infections are, and their outcomes. So not just clinical outcomes, but also functional outcomes. And we have a network of 40 to 50 hospitals. This map is not yet updated. We are talking to 7 hospitals in India and 3 or 4 in China at the moment. And actively enrolling sites are 27 sites. And as I explained earlier, we are combining individual-based, patient-based data, combining clinical data, microbiology data, genomic data, and health economic costs to make that comparison between antimicrobial resistant infections versus susceptible infections. Yeah, and currently we've already, as of this week, I think 2,500 patients. We are enrolling at about 100 patients per week. I will invite everyone to hazard a cost how much this kind of a study take. Surveillance study, yeah, no intervention, simple, right? It is taking a team of, in our email list, there's 355 people, 6 million pounds, right? Just to do this for 2 years. And this is why we don't have good burden of disease data. And this is just super fresh data from the first about 2,000 patients. Fresh meaning there may be errors here, don't quote me. Completely secretive here. We can see again the predominant infection bacteria is caused by gram-negative infections. And over here, you can see meropenem resistance is over 40%. Yeah, for me, it's a moment of, you know, what? But then when I talk to the colleagues in the region, they everybody is like, oh, that seems reasonable, or that's not too high, right? So when I went to, for example, Medan 2 weeks ago, on a workshop on a weekend, and the colleagues over there came to ask me, oh, we did this study, we realized there's a lot of carbapenem resistance. How do we treat our patients with carbapenem resistance? Or I said, oh, in Asia, we don't have access to newer good antibiotics. But we have polymyxin. Polymyxins are the antibiotics we give to our pigs, right? But then now it's used back in the humans because we are out of options. And then they tell me, oh, we don't have polymyxin. Or we don't have colistin as well. Then I ask, what do you have? They say they only have one type of carbapenem to treat carbapenem-resistant infections. That's the kind of situation we are facing, okay? Yeah, so that is the kind of epidemiological picture we are facing in Asia. So now we want to move back to our OHAP project and talk a little bit about modeling and how we can use the available data and our expertise here in the room, how to move forward. So I thought the steps that we can take can be summarized these 4 steps. Firstly, we identify the important stakeholders. Hopefully that's everyone here in the room. And together, today and tomorrow morning, we'll identify the main objectives and the outcomes of interest. What are the policies we would like to undertake, or we have the resources to undertake? And then with the modeling expertise here as well, we can select an appropriate modeling methodology. And eventually we can come back together and evaluate and interpret the model output. So as for stakeholders, I thought this paper summarized it really well. You can see over at the white angular shaped, I'm not a mathematician, octagonal, hexagonal shaped. These are resources, food, environments, sort of reservoirs of resistance. And then we have over here the different sectors in yellow, and the key players are in blue boxes. So as I was alluding to earlier, we really need to contextualize the issue. The situation here in Singapore will be very, very different, say, compared to Thailand or in China, for example, because we don't have a lot of farming here, and the main drivers or the main users of antibiotics are very different in Singapore. But then can we develop something that can be generalized to a whole Asian setting? And also, we need to together adjust our expectations. In the earlier 2 presentations, we have seen the kind of data that's available and the kind of work that people are doing around this area. What is really achievable with what we are trying to do here? It's probably not be all and end all kind of a project, but can it prompt further or guide further investigations and work in this area as well? And what the other links in the ecosystem that we want to involve in the future. And lastly, we want impact, but what impact is it that we want to drive home? So as for the objectives, I thought it's more like a ladder. So firstly, looking at the data that we have, is it enough? If it's not enough, probably not enough, never enough data. What do we need to assume from these data? And sorry for the typo, but what other data sets are important to capture as well? Do we need separate funding for those kind of data? And next step would be the mechanisms. So this will be the modeling or the methods that we want to adopt here to make use of the data to arrive at the solutions, so that hopefully with the models, we can sort of decipher what are the reservoirs of resistance, what are the transmission dynamics, and which reservoir and which transmission steps are important in this whole ecosystem. And lastly, the solutions. We don't have all the resources in the world. What kind of solutions are considered low-hanging fruit or cheap and also high yield, and what solutions are high yield but more expensive, and so on and so forth, so that we can prioritize our interventions. So this slide, I thought really summarized really well in terms of the modeling approaches over here. And I would like to focus on the compartmental model, which is what we thought would be a good solution. So this paper here, published by Bhutan, is this group worked very closely in the Thai setting. And their model is a compartmental model where they put together a human compartment, animal compartment, and an environment compartment, where each little black arrow here represents a step where resistance can be transferred, and also where we can adjust the rates of these transfers in terms of interventions that we envision that we can implement to reduce such transmission. And then you can evaluate these interventions after adjusting the parameters and seeing the impact of the interventions. Okay, so in this particular study, they used gut colonization data from Thailand, focusing particularly on ESBL producing E. coli. ESBL is a kind of resistance gene, which carbapenem is still effective for. In our Singapore setting, when before I left for my PhD, I did a study in Clementi where we found that amongst 300 people in the community who's never taken antibiotics, never been to the hospital, 1 in 4 of them carry ESBL E. coli in their gut. So it is here. And they also included animals and food data, and also in the environmental sources as well. But you can see in the parameters that they use, I'm not sure if I'm pointing the right thing, but you can see a lot of the parameters are very big, from 0 to 100%, because there's no data. But the beauty of such model is that you can just put in whatever parameter space you want and see, is this step even important or not, or sensitivity analysis. Okay. So we have Eve here, just to introduce her work. Yeah, so this is, she's so excited. Yeah, so this is their model, which is also making use of a compartmental model where they have a separate human and animal model. I shall not talk about this too much, but this is another variation of such a model which we can implement. Yes, so in this model, which is a sort of there's an added component of a health economic component in it. And as I've alluded to earlier, you can adjust the parameters or change the rates for the little arrows to see if it's important or if it's impactful to change or intervene those steps or not. So the strength of compartmental models, why we think this is a way to proceed, because it's easily interpretable, and you can easily manipulate it with various interventions that we think may be feasible. And we can add in as many compartments we want, as minute details that we want, or as general as we want. Relatively, we can, because of the ability to sort of control the number of compartments and the arrows in between the compartments, we can use, it is feasible to implement such a model with even very little data. But there are, of course, limitations. Within each compartment, we assume that is homogeneous. And of course, we humans here, we are all humans, will consider ourselves to be exactly the same. And if we want to have one compartment for humans, we will consider ourselves to be similar to farmers, to tourists, to everyone, right? Is that a suitable assumption or not? And then in the animal compartment, similarly, do we want to consider companion animals like pets or migratory birds and all that to be the same? And in the environment as well. And the more compartments we add, the more complexity there is, and the more difficult it is to fit the model. So the last 2 slides from me would be sort of highlighting the challenges and also adjusting everyone's expectation here. So predicting the economic burden of AMR and coming up with interventions hinges on the prediction of future AMR, but we cannot really predict AMR. It's like economics. We see some trends, but there's no way for us to really predict that, right? because of the emergence and the transmission of AMR is so difficult. Over previous few slides ago, I showed you all the different genomic mechanisms of just one single type of resistance in gram-negative bacteria. There's single versus bundles of genes versus clonal spread of resistance. There's various drivers of antibiotics. It's not just volume of antibiotics, but it's also the spatial sort of prescription or the duration or the dose or the way we dose our patients. All these things drive different kind of resistance. And in terms of transmission, the context is important. How good is it hospital setting? Is it community setting? And even within the hospital setting, how good is infection control, the environmental cleaning? There's so many different drivers. And it's really, really difficult to predict AMR. And the challenges of now, right? So as I was explaining earlier, the current burden of AMR is very difficult to quantify. The Lancet paper published last year has been cited 3,000 times in the last 6 months. And we've been talking about AMR since the 50s, right? And that is really the first sort of concerted effort to quantify the burden. But is it really a good estimate? We are not sure, right? It is costly to do it, time consuming, how we are doing it with 400 people. And the difference between attributable versus associated burdens. If you ask clinicians to my department, people would say, oh, Acinetobacter is not an issue at all because people die with it, not from it. But if you ask someone from Thailand, they will be so worried about Acinetobacter because so many patients are dying from it, they believe. But how do we differentiate that? We don't know, not very sure. Right, and also we have a severe lacking of data from the other sectors. Okay, so just want to highlight again, we are here together to think about the solutions. We already did some literature review, a lot of literature review to inform us about the data. But let's come together with all this background in mind, to come together and think about what solutions we want to achieve together.